Welcome to Against the Grain, a podcast that investigates unconventional ideas in science and medicine. My name is Dr. Samir Kakodkar. I am a gastroenterologist and a specialist in ulcerative colitis and Crohn's disease. This is part 2 of our conversation with a patient who just recently had surgery for his severe ulcerative colitis. We will mainly discuss how he feels now, what to expect post-surgery, and have a discussion about if he should go forward with the J-pouch. If you did not hear the first part yet, I would encourage you to listen to that first. So you had the surgery. How long ago was the surgery?
I had it first week in January.
Okay, and was it the right decision? How do you feel now?
Yeah, it was the right decision, like probably 110%.
Okay.
So I feel, 100 times better. I mean, it sucks. Obviously, having had the surgery and not having a colon is no fun, but comparing to what I was going through, it's crazy. I gained 35 pounds back within like 3 weeks. No joke.
Wow. Okay.
Yeah, it really was probably too quick, if anything. I could lose another 5 pounds.
Okay. So you're feeling better. You gained a bunch of weight. What other things have you noticed that have improved?
I'm off the steroids, which is killer. I haven't been off steroids for this long in 3 years, probably. And just with that, as we had spoken prior about, everything's better off steroids. I mean, except for my rosacea. But everything, my cognition, my just my attitude, the way I respond, it's just, I don't know. It's hard to explain unless you've been on high-dose steroids for a long time, but those that have would appreciate it.
So, and what about food? Are you able to eat whatever now?
I eat essentially anything. They tell me to kind of be careful with fresh fruits and fresh veggies, but they promote a high-carb, high-salt diet. It's kind of funny. It's like the opposite of what normal people would do. But yeah, the reasoning being obstruction, but. So, fruits and veggies with any sort of skin, you got to be careful with. You just eat it slowly and in small aliquots in the beginning. But I just had like an 8-week appointment, and they told me pretty much to eat anything. I'm still a little hesitant because I've heard stories of people getting obstruction. So, but yeah, I'm about to be free essentially in that sense.
Okay. And just to backtrack, what surgery did they do?
So I had total laparoscopic colectomy I had preservation of the rectum or whatever you call it. I did not do whatever the completion portion is of that.
Okay, so is this really a subtotal colectomy? The rectum's still there.
Yeah.
And
yeah, that's true. The proctectomy is still there. The rectum's still there.
And what was the recovery process like? Like, how long were you in the hospital? What were you doing during that time?
Yeah, so I think I had the surgery on a Monday and I went home on a Wednesday. I think it was that. I think I spent 2 nights in the hospital. There was literally no pain. I mean, it was bizarre. You had some, achy pain, like when you sneezed or moved, it would hurt, but if I laid still, there was no pain. So that was kind of interesting to me. I was expecting a lot more pain. I did take pain meds probably for a week just to kind of help me sleep at night. Because if you laid on my stomach or, if I pushed on it, it would hurt. But at rest, there was really no pain. The hospital was just laying in bed, reading or I don't know, mostly reading. I read like 4 books, and then I weeks off work, and then I was back at work.
Okay. And then how long did it take until you felt pretty much close to, as normal as you were going to be after surgery?
Probably like the 6 to 8 week mark, really, to the point where, I haven't jogged yet, but I think I could jog now, just because it's an odd sensation having an ostomy. But I think now, and then a lot of it is playing with the equipment. It's a lot of new. It's a whole new process, to change a bag, to have your skin prepped, to whether you wear a support belt, all that kind of crap. How to hide it appropriately,
Right.
There's significant swelling of the ostomy for a while, so all that is kind of trial and error, which I'm still messing with a little bit.
And can you give us some insights about the actual supplies?
The supplies they gave me like almost an 8-week supply from the hospital. I just put in my first order, like official order, but there's like essentially 3 main companies, so you order from them. So you do the trials. I change the bag every 3 to 5 days. I was wearing it a little too long earlier. You can get like more skin irritation or little fungal infections if you wear it too long. Mm-hmm. Essentially, the supplies are a skin cleanser. There's a disc, which is like these colloid adhesive discs that you put on the skin first, and then you put the bag on, depending, there's like a 1-piece bag, a 2-piece bag, and then if you're going to wear a little belt that wraps around to support it, those are all kind of optional that you learn with time. I think most people that are relatively active prefer like the 2-piece bag with a support belt. That's what they told me, and that's what I ended up with. So yeah, it's really easy to handle. I mean, I probably am a little more advanced because I've seen this type of thing, but it's pretty easy to handle, and changing it takes 5 minutes. Change it in the morning typically, or in the evening before I go to bed.
Okay.
And then you empty it. I have an ileostomy. I have all of my small bowels, so I empty it probably 3 times a day, anywhere from 3 to 5.
Okay. And the process of emptying it, is that a pretty quick thing? Like you just go to the bathroom and empty it out, and it just takes a few minutes? Okay.
I spend probably like 5% of the time in the bathroom I used to spend. Yeah, it's quick. It's just like dumping, like a sandwich bag full of water out.
Okay.
Pretty quick. Yeah.
So that must be real nice to have to spend not that much time in the bathroom anymore.
Oh man, like those kind of things is crazy.
Okay.
Those kind of like the amount of time, and then really like you don't have to ever empty it. You know what I mean? You have to empty it, but there's not a specific time. You never have an urge to empty it. You don't even know when it's full or not unless you touch it. So it's just like when I have to go to the bathroom to urinate, I'll say, I'll empty the bag while I'm here. Or sometimes I'll notice that it's full and I'll empty it, but it's not like, oh shit, I have to go to the bathroom.
Right. Okay. And I've seen people with bags that are like opaque or you can't see through them, and some that are transparent. Which one do you have?
You start using I think they send you home with all the transparent ones because you want to learn, like what the stoma looks like, what the output should look like. But now I use an opaque one in case it becomes visual,
Okay.
like it sneaks under my shirt or something like that. But that's the only reason, really.
So in our previous conversation, we talked about the question of the diagnosis, right? Was it ulcerative colitis? Yeah. Was it Crohn's because of these ulcerated large skin tags that you had, which are suggestive of Crohn's? But what did the pathology specimen of when the pathologist looked at your colon under the microscope, what was their diagnosis?
They said ulcerative colitis, or consistent with ulcerative colitis, which is really what I thought it was, to be honest. From my experience of like how many colonoscopies and sigmoidoscopies and everything, my symptoms overall and just kind of my overall status, I was suspecting ulcerative colitis, and they kind of confirmed it, really, I would say.
Okay. So you have an endoileostomy, and you also have a rectum that's out of circuit. It's not connected to the rest of your GI tract. So what is it like to have an out-of-circuit rectum? Like, is there stuff coming out of it at all? Or
like every third day in the morning I'll have like the kind of sensation that I need to use the bathroom, and it's just like a little mucus output.
Okay.
But again, it's not urgent,
Right.
It's like a normal person, I suppose.
Okay. That's good. It's just mucus, it's not blood coming out?
There was blood probably for the first, 6 weeks to a month. But I don't believe there is anymore now.
Okay.
And then, I got to decide whether I would go to a completion prostatectomy or, try to do a J-pouch or that kind of stuff. So I don't know about that yet.
So
or surveillance.
Yeah, that's really the decision you have to make at this point. I mean, you don't have to make it now, but it's something to think about.
The next step, really.
And, in preparation for this conversation, I did kind of look some of these things up as far as what really are the numbers as far as your risk of getting pouchitis. And according to the literature, at about 10 years, 50% of people who have a pouch get some sort of pouchitis, usually like an acute episode, and a certain percentage of those become chronic. But 50% pouchitis at about 10 years, and then at about 20 years, it's about 70 to 80% of people will have at least one episode of pouchitis. Now, what percentage of those people who develop acute pouchitis actually go on to have chronic pouchitis? And that number is about 10 to 15%, according to the most recent ECHO guidelines. So, and as far as what are the risk factors, like what are the things that have been associated with people who go on to develop pouchitis? And there's a few things. Like one of them is if you've had extensive ulcerative colitis, meaning ulcerative colitis extending beyond the splenic flexure, so more than left-sided colitis, which I don't think you had, right?
Yeah, well, that's a little bit undetermined, I would say. I mean, I've had a colonoscopy where they told me there was scarring and signs of, total colon inflammation, or that I had ulcerative colitis throughout my entire colon. And then the final path said like 40 centimeters of active colitis or something like that.
Okay. So a little bit unclear there. Okay. The other thing, and the other risk factor is PSC, primary sclerosing cholangitis, which is a liver condition, a type of inflammation and narrowing of the bile ducts that can occur with ulcerative colitis and Crohn's colitis. My understanding is you don't have that, so that's not a risk factor.
Yeah, doesn't appear this. So.
And then if you're a non-smoker, it's actually a risk factor for developing pouchitis.
Yeah, I'm not a smoker. I thought about starting smoking, but I never did.
Right. And then also, did you ever get IBD serologies, like these blood tests to tell you if you actually have ulcerative colitis or Crohn's? Did you ever get that done?
I never did, no.
Okay. There's a certain marker on there called P-ANCA, which if your P-ANCA is positive, you're more likely to develop pouchitis after colectomy and if you have a pouch made. And then, of course, NSAID use is a risk factor too. So those are the risk factors we think about as potentially being associated with developing pouchitis later.
Yeah. I mean, it makes sense. Just globally, all those percentages are what they are. But same thing as with Humira or Entyvio or whatever. There was always 20%, 30% were going to respond. 70, 60% were not going to do anything. And, I was always the worst case from all of those medications and from all of even the way I was responding to prednisone. So I'm kind of just extrapolating that into that. I would have to kind of plan on getting pouchitis at one point. And am I willing to do that again? Am I willing to try, get on more medications? Right now I don't take any medication. I take a vitamin D when I remember and a multivitamin when I remember. But, that's it.
Yeah.
And it's pretty awesome.
The thing about pouchitis is, as I cited those numbers, the majority of people do get an episode, but the vast majority of people are responsive to a course of antibiotics. There's certain things you can do to prevent it, like use probiotics, like VSL number 3, which you were on before, I believe.
Yeah, it was.
But, yeah, it's a tough decision. Are you leaning towards one or the other at this point? I mean, now you've got some experience with an ostomy. Is this something you think you could deal with for a long time?
I definitely am leaning away from any more surgery if I can avoid it. But you never know. Things may change. But, yeah, that's where I'm at.
Okay.
And I can only see it really getting better in the sense of becoming a little more slick with hiding it and knowing, trialing. There's still many products I haven't trialed for it. So, but at this point, I would definitely, I'm kind of leaning against it, but I am at the point, I'm married, I have kids, I'm active, but I don't do anything crazy, so, having the pouch doesn't really limit me in any way at this point.
Yeah. I think if I were in your shoes, I would make the same decision.
Yeah.
Sorry, go ahead.
Yeah. So, no, it just, if anything, it's just opened up my, ability to travel or like do any sport. I mean, I wasn't able to work out before because I was always going to have to go to the bathroom. I mean, it was crazy. So now I think I can. I mean, I can do almost anything or anything really.
Yeah, and do you really want a pouch where the average number of bowel movements after you have a pouch put in is, around 6, but can be up to 10, which is normal, and you could have like about a 1 bowel movement to wake you up at night. I mean, that's possible too. So it's almost like you're trading one problem for another. Now you're going to have, frequent bowel movements. Usually they're not associated with the kind of urgency you had when you had active disease, but still you're going pretty frequently. So to me, it makes sense to just stick with the ileostomy.
Yeah, honestly, I mean, that's where I'm at. And then, excuse me. And then the question comes into, do I do the completion prostatectomy for cancer prevention type of thing? Which that I'm not really sure. I'm kind of leaning towards surveillance, but I don't know. Yeah, I'm up in the air with that. I got to do some more research and kind of see how things go, I guess.
Yeah, that's also having an out-of-circuit rectum needs surveillance, and ultimately how often that's done is, did they tell you that they want to do it like every year or? What?
Yeah, I think they said started out like 2 years or a year afterwards, and then they're every year or every third year. They weren't clear, but you just got to develop some sort of a protocol, and then I'm sure, depending on the amount of inflammation that probably thereof or lack of, probably dictates when you do your next.
Right.
Or dysplasia or whatever is going to be there.
Mm-hmm. All right. Is there anything else that you've kind of learned from this experience that you didn't know that you wish other people would know?
Yeah, a lot of people say, you're gonna wish you had done it sooner. I wouldn't necessarily say that for me. I mean, I'm definitely happy, and I wouldn't go back and wait any longer. But I needed to really exhaust every option to be able to accept this, and maybe that's why I am so accepting of the situation. I mean, like we had said, I did the hyperbaric, I did Entyvio, I did Humira, Remicade. I did everything that you could do, essentially. I did all the probiotics, obviously. I did do some kind of quasi-homemade fecal transplants. I mean, I really tried. I felt everything I could within reason and didn't really get any response. So then it made me kind of, okay, I can go ahead with this and still have a peace of mind. So in the same sense that, I have I'm very, very close access to physicians, hospitals, so I was taking some risk. I mean, it could have went south. I could have gotten to an acute episode and then had the surgery, and it would have been a lot messier. But I feel like for me it was the right approach. So, yeah, that's it.
Okay, great. Let's see. And then, the first, it was funny, the first podcast we did, and I know we talked about this, there was actually a little bit of, I got feedback from a few people. They were a little bit upset about what we said about the specific carbohydrate diet, when really I think, we were agreed that we're pretty complimentary towards it, that we thought.
Yeah, I actually recommended it to somebody today, the diet.
Oh, really?
Who was having, other issues, but I just said, not even IBD issues, just overall inflammation and kind of psoriasis-like issues and some other things I thought contributed to like a personal biome kind of theory, and I recommended it to him. I said, this is a great diet. I really think it has potential. But it just didn't. I definitely gave it a fair shot, and it didn't work for me. So, and that was just the gist of what we came to, I mean.
Right.
And I feel I'm a relatively educated person, both on diet and medicine and personal metabolism and that kind of stuff, and I did it appropriately, and it didn't work. I mean, it's not going to work for everybody, and that's just the truth.
And that was the intention of bringing it up and presenting your case, is that I'm not trying to say that it doesn't work and it's not worth trying, what I'm trying to show is that there are definitely certain people who don't respond to it. Now, there were specific criticisms, and I didn't get a chance to really go through them in detail, but I felt like people whenever someone does not have success with the diet, there tends to be this attitude that, oh, you didn't do it properly, or you were doing something wrong with it. And I imagine maybe when people listen to your story, that maybe that you were on Cipro at the time may have influenced the efficacy of the diet. I'm just trying to anticipate what people were saying.
I did do Cipro during it, but I did the diet for like 6 months for real. I mean, like, you know, my wife thought I was crazy. We were kind of crazy at that point. But I mean, I was willing to do anything. I said I would have eaten grass every day if it worked. You know.
And many of the people who have had success with the SCD have been on antibiotics. I mean, it's not like, and many of them have been on antibiotics concurrently with the diet and eventually kind of like weaned off of them. So it's not.
Yeah, that was kind of a little bit my kind of theory or my thought process. Like, wipe everything out and then use the diet to reestablish what I want to be there. And that crossed my mind. I did try the diet, by the way, first without antibiotics for a significant amount of time, and then antibiotics with it. I mean, I was like pulling everything out of a hat, you know. Right. At the end, I was doing hyperbaric with the diet, you know, towards the end.
Right. No, I mean, there's definitely people who just don't respond. I've seen. Definitely seen that, and it's just and there is no treatment that's going to work for everybody, and even the people in the SCD community have to acknowledge that there are people who don't respond the same way there are people don't respond to Remicade, people who don't respond to biologics, medications. There's some people who just don't respond to anything, and that includes diet. So I think there's this attitude that, oh, everyone who had surgery could have avoided it if they just went on the diet, if they just knew about the diet. And your case is illustrative that you knew about the diet. You knew about the diet relatively towards the beginning of your diagnosis. And
I mean, I tried that diet. I tried other diets. I tried every medication. That's what I'm saying, that I would have been pissed if you guys solved this month with the SCD diet and I hadn't tried it. Right. You know what I mean? Like they're saying. And I still would be pissed. I will be pissed when they solve it one day probably. But, you know.
And I always used to wonder, I see these patients in the hospital who get surgery all the time, and I always used to wonder, and a lot of them don't try diet, and in the back of my head I'm thinking, oh, maybe if they tried diet, maybe the outcome would be different, but we don't have that data. We haven't studied this diet in that particular patient population, the people with severe steroid-dependent or steroid-refractory ulcerative colitis, and who knows if it would work in those people or not. There's definitely people on the internet or on message boards, people I've met who've been in a similar situation where they were facing surgery and then they refused surgery, they went on the diet, and they didn't end up getting surgery. That definitely has happened.
And I still think if I had, I started out, it's kind of an indolent disease. If I started out with pretty much just proctitis, maybe if I had gotten on the diet way back then, like right when I got diagnosed, that would have been similarly if I had gotten on Remicade, I think, at that point. If at all, if it was going to work, that was the only time for me. So I regret that, maybe, not taking it seriously enough in the very beginning. Not to say that it would have worked, but I think in my case, if it was going to work, that would have been when,
Right. And then there's no way to know. I mean, it's...
No, yeah. I hope it wouldn't have, just because of, I hate to think that I could have stopped it, but, you never know.
And there is data to suggest that people really with severe ulcerative colitis, even, in 1998 is when Remicade was approved. And since then, it's been considered kind of the biologic era where we have these medications, these protein-based medications. And for people with severe ulcerative colitis, it really hasn't changed the surgical outcome.
Yeah, I've looked at that data also, which I thought was interesting.
Yeah, it's more mild to moderate cases where it prevents surgery. But for the people with severe colitis, it doesn't seem to have an effect on the amount of people who end up getting surgery.
Yeah, and maybe it delays it for a certain period of time, but the ultimate end game, people end up with the colectomy,
Right.
So, yeah, well, it is what it is,
Yeah. But I'm glad. It seems like this has been put behind you. This big cloud over your head.
It's funny. I used to tell Maria, that my wife, that it's like I always know that I have a colon. Before, like, she asked me how it felt, or like, does it hurt always? Or I'm like, it doesn't always hurt, but you can always tell that your colon's there. It's kind of an odd sensation. Like, there's at points when I forget, definitely that I forget I have the ostomy, but then I just kind of forget that I ever had ulcerative colitis, which for the other past 3 years I probably couldn't say that.
Yeah, so
that's nice.
Big detour in your life, but now you're back on track, and you can put this behind you.
Yeah, and people don't know. I mean, I don't tell any of my friends. I guess if they hear this, they'll know. But I mean, really, only a handful of people know I have. Number one, that I had ulcerative colitis. Number two, that I had the surgery. I was able to hide it, I think, to a certain degree. People probably thought I was like on drugs or something, but now I'm kind of back to myself.
And that's the unfortunate reality of these diseases, is that people suffer in silence. It's something that most people don't want to talk about. One piece of advice I would give is that it depends. It depends on your situation, where you are in life. Of course, if you're like already married and already have a family, versus if you're like single, but I think allowing more people to know, especially people that are close to you, it just makes it more to suffer alone and in silence and not express what you're feeling. You should at least have a few, like a small group of people who know what you're going through, and that. I
agree, and really, the more that know, the better. I agree, but I still don't tell people, even though I say that, and I definitely don't tell people about the ostomy. I mean, I talked to a guy who through the university who has had an ostomy for 25 years, and he's like, "Oh man, the best thing I did was tell everybody about it."
Yeah.
But I'm not to that point yet. I probably will. I can see myself getting there, but it's just something that I prefer to hide still at this point. But
it shouldn't become who you are. Like, who you are is not somebody who had ulcerative colitis who had a colectomy. So it's just something that happened, but that doesn't define you, and it isn't what you are now. I mean, you're a surgeon, you're a physician, and you're continuing with your life, and this is just something that happened. Yeah. So that's another thing. It shouldn't come to define you. What happened, but it does.
It feels like it's good. That's what I mean. Definitely, while you have it, it feels like it's good. And now, every day, I feel more and more kind of acceptable with it, or accepted.
Yeah.
So it's kind of interesting. Yeah.
But I do think when you go through something like this, when you come out of it, you do see the world in a different way.
There's no doubt.
And you don't sweat the small stuff as much. I feel like it does make you stronger in multiple ways.
That's the truth, honestly. And this thing would have killed me if there wasn't modern medicine today. I mean, I think the death rate of ulcerative colitis, in the early 1900s was like 50%.
Yeah, before steroids, it was very high.
Yeah, this thing, there's no doubt. I mean, I was like close to dead at some points of just like not eating, and my hemoglobin was so low, and I mean, it was crazy. So that you got to be thankful, or I mean, not everybody, but the people who got out of it. At one point, I mean, I'm thankful at this point that I'm not, one, that I feel good, but two, that really that medicine was, and it turned out to be surgery, but for me, but that I was able to kind of get out of it. So, we'll see. Ups and downs, man. That's how it goes.
Yeah, but hopefully it's smooth sailing from here. I hope everything goes well from here. If your plan is to continue with the ostomy and just go with the surveillance, or maybe at some point in the future you think about doing the completion proctectomy, so you don't have to keep getting those scopes, that's also reasonable, but there's no rush for that. And now you can eat what you want. You can get on with your life. Yeah. But I think what we've done here is very unique in that we interviewed you right before surgery. And that's a very tough period of time for people. A lot of people are in the hospital at that time, and they don't really have a lot of time to to
I
think
probably
about
should
it.
have been. But yeah, you're right. It's just like it was a tough time, and it was right before, and I really was delaying it, man, till the last minute. So you saw me at the prime of my bottom.
Yeah.
Or you heard, yeah.
And
you saw me also, but
I think this will be very helpful because I plan to promote this podcast to people who are facing surgery, just so they can see, because a lot of them didn't do all the things that you tried.
I mean, not everybody has kind of the option, right, or the means
to
do that. So that was kind of the key. And it, just because it didn't work for me, I'm not saying people shouldn't do it, shouldn't try it. But I think.
I think it is very
different strokes for different folks.
Yeah, and they can learn from your story, see what someone did who went to the limit, but still had a good experience after having surgery.
Yeah, overall, I had I would say, like you said, it was a learning experience, and I've appreciated it, and I'm kind of, in a way, it's almost a thing you're glad you went through.
Right.
At one point. Maybe that's probably the wrong thing to say. I guess maybe I'm feeling a little extra happy right now, but All right, brother. Well, I'm getting home. I gotta let you go, but I think, like you said, I think this can help people, and I told the people at the hospital I'm happy to talk to people over the phone, and to kind of tell people my experience and things I learned, both the good and the bad.
Great. Thanks a lot for sharing your story. I really appreciate it. It's going to help a lot of people. And, hopefully we can have you on sometime in the future, years down the line to see how you're doing.
Yeah, I'm happy to. Happy to, man.
Okay. All right. Thanks a lot.
Yeah, have a good one, man.
Okay. Bye. Thanks for listening to this episode. I do anticipate having many more guests on. Hopefully we'll have some more scientists and physicians and also patients who have a unique perspective on Crohn's disease and ulcerative colitis. So please do download an app to listen to these podcasts. There are multiple that are available through the iTunes or App Store or the Android Store. And please do subscribe to this as well so you get automatic alerts when there's a new show. Again, thank you for listening.